Good afternoon and welcome to our Learn and Share conference call. I'm Russ Derry. I'm the Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is EEG 101, and we're pleased to have as our speakers Dr. Ryan Keating, who's an epileptologist at Michigan State University, and Kimberly Patterson, a neurodiagnostic technologist at Michigan State University. So thank you both for joining us today. Can you just briefly introduce yourself and talk a little bit about your clinical and research interests and describe your experience with this topic?
Yeah, so my name is Kimberly Patterson. I'm a registered EEG tech and the department coordinator for the EEG EMG lab here at MSU, which is Michigan State University. I'm also the program director and instructor for the MIRIS Consortium's Neurodiagnostic Technology program. So we are happy to report we are just starting our second year of that program, so very exciting. We just graduated 7 students here in May, and we have 28 new students coming our way in August. I spend half of my week in the clinic at MSU. I still do EEGs, I do nerve conduction studies, and I coordinate a neuromuscular research trial as well. And the other half of my week I spend teaching EEG techs how to do EEGs.
Great, great.
So my name's Ryan Keating. I'm a neurologist at Michigan State University. I'm at the main campus in East Lansing, and I trained in my residency for the first 4 years in neurology, and I did that at Beaumont Hospital in Farmington Hills. Then I did my fellowship at Henry Ford Hospital for about a year in something called clinical neurophysiology. Clinical neurophysiology is a fancy term for being trained in being able to read EEGs and treat epilepsy, read EMGs and treat neuromuscular disorders, read something called interoperative monitoring, where we actually, during operations, will read EEGs and EMGs, and then also something called continuous EEG, where we have people hooked up for a certain amount of time. I'm currently in practice at Michigan State University, and I see patients in the outpatient setting with epilepsy about 20 to 35% of my time, and I work with patients in general neurology complaints and also multiple sclerosis the other part of the time. I also work on the inpatient setting, seeing patients with general neurologic complaints, run the epilepsy monitor unit, and read routine and longer-term EEGs at Sparrow and McLaren, as well as for Bronson. And the Michigan State Epilepsy Department itself has 4 epilepsy specialists and soon to be 5. And we're currently in the infancy of our non-pharmaceutical studies regarding epilepsy care and outreach. And so we do a lot of pharmaceutical stuff, but we don't do a lot of surgical stuff yet. But that's one of the plans to bring things online as we develop as an epilepsy program. And then I'm also involved as a sub-investigator for 2 studies in Biogen and Eisai.
Okay, great. So, in a nutshell, what is EEG?
So an EEG is an electroencephalogram or brainwave study using a number of specialized electrodes and an amplifier and digital converters to take things from information that's coming from our brain, which is very, very small voltage differences, and turning it into information that we can actually see on a screen. And so those individual voltage differences that we see are caused by individual or groups of nerve cells, and we're able to take that information and interpret it. And it's kind of like an EKG or an electrocardiogram rhythm strip for the heart, but it's for the brain. So after decades of doctors and technologists reading these studies, we've been able to find patterns that are normal or abnormal. And if they're abnormal, are kind of telling us, are they epilepsy or do they indicate an increased likelihood of seizure activity? And so that's called epileptiform. Or if they're not epileptiform, are they abnormal, like slowing in parts of the brain? So EEGs can be interpreted by general neurologists or subspecialty neurologists. So subspecialty neurologists include epileptologists, clinical neurophysiologists. As time goes on, currently, we're doing having less and less general neurologists reading these EEGs. or using the help of subspecialty neurologists for complicated studies. And so when it's complicated, then they send it to a subspecialist who looks at things. When I talk to my residents about looking at EEGs, it's kind of looking and reading EEGs is kind of like bird watching. And so the more birds that you see of a certain type, the more you're able to interpret it as something that's abnormal or normal. And so the more experience and the more time you have reading abnormal studies, the better that you are able to make your opinion if they're normal or abnormal.
Okay. And Kimberly, did you have anything to add? Or?
Yeah, I mean, I can actually talk about what we do to prep the patient and kind of how we do to, or what we do to hook them up.
Sure.
If that sounds like a good idea.
Yeah.
So EEG is a non-invasive test. So it may be a little messy, but the good news is it does not hurt. The technologist will measure and mark the patient's head using a grease pencil and a measuring tape. Measuring the patient's head ensures for perfect electrode placement for all 28 electrodes that are going to be placed. So everybody has a unique head, and so everybody needs their own special set of measurements. After marking, the tech will scrub each spot with a gritty type of electrolyte paste, and then fill the electrode cup with a conductive paste and place it on the prepped spots. After that, the tech can choose to wrap the patient's head to keep all those electrodes secure or leave them be. And after that, it's time to record. So the technologist will guide the patient through the test. So likely at some point during the study, ask them usually about 3 questions to document their baseline. Questions can be simple, like name a red fruit or what's a major holiday in November. And they'll also ask the patient to do some eye opening and eye closing. It sounds a little silly, but your brain waves are actually different when your eyes are open or closed, and we like to see both. They'll also perform a couple tests that we call activations. There are some contraindications to that, but generally most of our patient population can do those. One is a deep breathing exercise, which consists of 3 to 5 minutes of deep, rapid breathing, and the other is photic stimulation. So for photic stimulation, the patient will lie still while a bright flashing light is placed about 10 to 12 inches from their face. And the light's a strobe light that will flash at different frequencies. So the light has a few purposes. One of them is to see if the brain is tracking the light symmetrically, and the other is to see if any abnormalities arise from that stimulus. After our activations, the patient will be asked to relax and try to take a nap. The best EEG is one that consists of both activations and a recording that has the patient awake and asleep. After the nap, the test is complete, and the technologist will end the study, remove the electrodes, and clean up the patient's head. So what I was just describing, Russ, is just a basic routine EEG. So there's, as we know, there's several other ways that we can do an EEG, but that would be the basic routine study that would consist of about a 20-minute recording. Mm-hmm. And with the prep of measuring, marking, electrode application, it's likely going to produce about an hour to an hour and a half appointment time. Of course, the neurologist can order a longer recording, which would, of course, be a longer appointment.
Sure. And we'll talk about the other types of EEG shortly. So,
mm-hmm.
Great.
Yep.
So patients receiving an EEG should expect to have the findings verbally explained by the neurologist in a way they can understand. In the written report, though, it can be pretty challenging for a lay person to figure out what the findings mean. So can you review what some of the key terms are in EEG interpretation so patients can at least have some idea of what written reports are saying?
Yep, so I'll do my best. And so after receiving an EEG, depending on its duration and type, it may take up anywhere to 24 hours to 1 week to interpret. Your physician should give you expectations regarding the reporting of the results to when the test is ordered. And so the physician should really be driving and saying, look, we're going to do this study, and it will get done in this amount of time, and then by that time it gets interpreted. And so that you guys know, you can always ask your physician about what kind of standard time, and then you can always 24 hours to 1 week doesn't seem unrealistic after the study is done. Unfortunately, at this time, there's no required standard EEG reporting. There are only recommendations, and so there can be a big difference in the reporting style from professional to professional. And so typically neurologist reports are broken into discrete sections, starting with the study indications, giving the reasons why you're having the study done, medications you may be on, and then previous studies that are done. Then the next section is the technical section that just gives some information about the recording style and type that we do, kind of stuff that Kim was talking about before. And then the next is the description, which is our fancy terminology of putting into words the picture that we see. I wouldn't expect most people without a neurophysiology degree to understand what this means. And then the next section is the EEG diagnosis or impression. It's the section where we take the key findings in the report and detail them for the ordering provider to reference. And so that's where we kind of state what certain terms that you may see, and I'll explain those later. And then the next is the interpretation. Some people will put this in the recording or not. What they do is they take what they see in the EEG diagnosis and impression and kind of put an interpretation of what it means for the ordering provider. Realistically, the ordering provider should be relaying the information or the findings. It's not just a report where we read like the lab study. And so it is difficult and sometimes a perilous task for patients to interpret the EEG results. Things that may sound abnormal may be normal and vice versa. And so there's some key terms that I come across and I read all the time in my reports and I write all the time in my reports. And so there's the term epileptiform, and so that means interictal. It could also be terminology as interictal epileptiform discharge, interictal epileptiform activity, interictals, seizure-like activity. And so this is where the brain waves are abnormal brain waves, which occur in between seizures and are thought to be the signature of an underlying seizure disorder or epilepsy. These may be focal, which means that they're in one part of the brain, or generalized, which means they're all over the brain. There's also another term that I think is an important term, benign variant, and so you may see that sometimes people have sharply contoured or interictal-looking discharges, but they call it a benign variant. And so really kind of like I was talking in the first part of the question, over a long period of time by having EEG epileptologists and technologists looking at the studies, we found that there's things that can look very abnormal but are benign, and they're normal things that our brain does, and it's just weird. And so benign variants are these brainwaves that may look abnormal, and if you're untrained about it, they are in fact normal. These are commonly misinterpreted as normal by people with less experience and may be found on subsequent studies to be reinterpreted by normal. This can happen sometimes when somebody has events that might not always be epilepsy, and then they go to an epilepsy monitor unit and we capture these, and then we ultimately say, you know, these aren't epileptiform, these are actually normal variants, and we should really find out what's going on with your diagnosis. The other terms that we see are encephalopathy, which is an abnormal brainwave finding, but it's not epileptic. It usually means diffuse background slowing, so there's just slowing of the background. We have a normal rate or rev that our brain should run, or a frequency, the number of brain waves per second, and sometimes if it's slower than that normal, we can call it encephalopathy. If that happens all over the brain, it's nonspecific and generalized as an encephalopathy. Or you can have focal slowing, where you have slowing in a certain area of the brain. This may or may not indicate a focal area of abnormality in the brain or a localized area. And then seizure is typically electroclinical, or electrical or clinical. You can see it on EEG or clinically, or you can just see it on EEG, clinically silent, called electrographic, where there's buildup of activity that's hypersynchronous, meaning it's fast and it's very rhythmic in one part of the brain, which is focal or generalized. And so those are some things that you can see. I don't know, Kim, did you have anything to add? Okay, and so I think that's it for that question.
Great.
Because next question, Russ.
Yeah. So can you describe the different types of EEG, how they differ, and the circumstances in which they should be used?
Sure. So we'll kind of break them down into a few different EEGs, and I'll try to be as brief as I can. And so there's routine EEGs. These are different time periods, both with and without video, and they can be done on an inpatient or outpatient setting, and they can last anywhere between a half hour to up to 3 hours. That's just for the recording time. That's not for the setup or tear down, like Kim was talking about before, putting the electrodes on, taking the electrodes off. These studies are diagnostic and typically without adjusting medications and may capture the awake and sleep. Sometimes we may ask that you are sleep deprived, like we were talking about before, for these studies so that we can capture sleep. I would use these typically on an inpatient setting when somebody is confused or out of it to see what their brain function tells me when they cannot tell me what's going on. Or I might use it in the outpatient setting. I can use it as an initial test as a low cost and time test for good yield on finding an underlying abnormality. So that's one. Then the other one is something called an ambulatory EEG. We typically do these at home. You would come into a hospital or an office setting and you'd be hooked up, then you'd go home, and you can wear the device for anywhere between 24 and 72 hours. And you'll typically get a piece of paper and you'll note down whenever you have an event or something concerning that we're looking for. And this study records you while you're doing your day-to-day things. And so I'd use this test for a number of reasons. When the patient has no known diagnosis of epilepsy or has a diagnosis of epilepsy and has new events which occur daily or multiple times per day. And so I can try to capture these events and tell them without sending them to something like an epilepsy monitor unit, which we'll talk about shortly, if these are epileptiform or not. Are they seizures or not? And so that's a good test that's home, and people like it because it's a little bit more comfortable. Typically, they are commonly done without video. However, there are certain companies that do them with video, and the video is in they typically put the video camera in 2 rooms, the main living area and then a sleeping area, and so that we can record you. The big drawback of that test is that we don't really adjust medications when people are hooked up because we can't protect people against seizures if they have them, and so we only use it for people who we're kind of getting a cursory look for events that aren't dangerous, and so that's that part of that. And then we also have video monitoring with continuous monitoring, and so this is only done on an inpatient setting when a patient has continual events concerning for something called status epilepticus, and that's uncontrolled frequent recurrent seizures, or other significant activity where we want to evaluate the patient in a critical state in the hospital. And then there's a video EEG monitoring in an epilepsy monitor unit. This is when you're admitted for at least 2, but sometimes up to 21 days, and we capture your events and decide what is the next step or correct step in treatment. We may decrease you at that time or take you off of your medications. We may sleep deprive you. We may use activation procedures like the hyperventilation and photic stimulation that Kim talked about before. We may have you exercise, and in some rare situations we may even give people alcohol to capture a seizure or multiple seizures. The nice thing about this is you're in the hospital in a safe environment, and so it's really the only place that, and most epileptologists say the same thing, it's the only safe place where we want you to have seizures because it guides us to what to do next. And those studies can be broken into different subtypes. And so we can have diagnostic studies, and those are when we don't know if you do or do not have epilepsy, and we want to capture these events to make sure they're epilepsy, because things that are not epileptic don't respond to epilepsy medications, and sometimes they can indicate something like conversion disorder, which may benefit from some psychiatric treatments, or something else, like does somebody have passing out or cardiac problems or lung problems or other neurologic conditions like movement disorders or tics or tremors. And so it's a good test to help us guide or kind of figure out in a fork in the road where the next step to go is. If we do know that you have epilepsy, and we suspect you're refractory to medications, which means that you're on a number of medications and still having seizures, then we would want to admit you to capture your seizures, to tell us where they're coming from, to see if you're a candidate for epilepsy surgery. And sometimes if that's the case, then we can't always localize where it's going. We can put you into something called phase 2 monitoring, where we bring you back into the hospital and we use intracranial electrodes, or electrodes inside of the scalp, so on the brain or within the brain, and we try to pinpoint exactly to a very small degree, typically a sub-centimeter, where the seizures are coming from, and so that we can either resect the location, and so we do that, we remove tissue if the brain part is not eloquent, which means it doesn't have a significant function, or we can use a device like NeuroPace, which is a responsive neurostimulator, a system which detects a seizure in an area and stimulates the brain tissue to stop the seizure, or a deep brain stimulator, a system which indiscriminately or discriminately stimulates the whole brain to stop the seizure from happening, or a vagal nerve stimulator, which stimulates the vagus nerve, but it has connections to the thalamus, and the stimulation can reduce the seizure frequency. And so those are kind of that part of it.
Great, great. Kimberly, did you have any other thoughts you wanted to add?
I think the only thing I would add to that from a tech perspective is going to be that the setup for most of these studies is generally the same, of course, outside of a surgical situation with the intracranial EEG. But the other studies, really the only difference in the setup is going to be the adhesive that is used. So if you're going to be in an epilepsy monitoring unit, the tech may use a strong adhesive called collodion. They're going to use that to keep the electrodes in place for a longer time versus what we may use in a routine setting. A lot of that, though, is dependent upon the facility that you're at. So there are different hospital protocols and that sort of thing for what we actually use. But the idea, generally, the setup is the same.
And just on a practical side note there, how do you recommend getting that out of your hair? Is there a particular technique or product that is helpful in getting that out? Or are the EEG, are you able to do most of that for the patient, or are there things that people can do at home if there's still residue? Or
yeah, absolutely. So really, the technologist should do their due diligence to get the paste out of the patient's hair. Okay. So if you're in an outpatient setting or even in the hospital, the technologist usually, if the electrodes are applied in a routine fashion, warm water is really going to break down the conductive paste. And then just shampoo, regular shampoo. After you hit the shower one time, that paste really should be gone. But really, when you leave a facility, if I have a patient come into the lab for a routine study, there should be no visible paste on them. Their hair might feel a little, sticky or a little crunchy, but really it should be mostly out, just residue, and then one shower should take care of that.
Got it.
If you're in a situation with a long-term study that they're actually using the collodion, that can be a little tougher to get out. The tech is likely going to use either a Mavidon or an acetone to get the adhesive off, and that can make your hair look like you have a severe case of dandruff, and nobody wants that. So what you can use to get that out is really any kind of oil, and it could be like vegetable oil, even like olive oil. If you put that on your hair, on your scalp, and then use a fine-tooth comb, those flakes that kind of look like dandruff that are actually the dried glue will stick to your comb, and you would just comb through your hair and then go ahead and rewash to get the oil out.
And should that be extra virgin olive oil, or I'm just joking?
Whatever you have at home.
Right. No. Okay, great. So how much does insurance coverage or lack thereof impact the frequency and type of EEG studies that you can order?
Yeah, so this is a tough question. A lot of people ask me about it. And so I think in the future, the way that healthcare is going, we're making it more easy and available to get the information of what is the cost to patient for certain studies. But it varies from facility to facility, and it varies from study type to study type. And so the answer really depends. Unfortunately, given the wide variety of insurances that exist, copays and coverage depends. And so most studies under 24 hours vary on cost from as little as $300 to as much as $4,000 direct cost for professional and technical components. A number of hospitals and practices will typically work with the patients who don't have insurance to give them a specialized, subsidized program cost for the study. So you can speak to them about that. I suggest you contact your insurer, and they can give you an idea of the coverage, and contact the ordering provider's billing departments, and they can give you a cost estimate.
Okay, great. So can each of you describe your role in conducting and interpreting EEG studies?
Yeah, I'll go first on this one, Russ. So as a technologist, it is out of my scope of practice to interpret an EEG. So patients will frequently ask, what did you see? And we have to tell them, I really don't know, you're going to have to wait for the neurologist. And really, you really want that interpretation to come from your doctor rather than the technologist. They are the ones that have studied extensively on this topic. And although we know quite a bit, it's really best coming from your neurologist, and it is certainly out of our scope to give those interpretations. There's a little variability there, though, because it is our job to report urgent matters to the neurologist as soon as possible. So if I were doing a study and the patient had a seizure, I would need to report that right away. I would also need to alert emergency help if I had a patient that was having a seizure that wasn't ending. So if the patient was in status, it's definitely my job to alert a neurologist immediately to get them help. I am also not allowed to administer emergency medication, but I am certainly expected to alert the appropriate staff to do so. So we are a frontline reader in that respect, where it is our job to notify, but we do not give diagnoses or, thoroughly give a report. The report that we do give is really just for the neurologist, and that's going to be, we document the patient's history, and we certainly document several things throughout the study. So during an EEG, the tech is really the neurologist's eyes and ears. So especially if there's no video attached to that study, anytime the patient makes a move or a twitch or anything's going on, it is definitely our job to be documenting throughout that whole study what exactly we are seeing. And it's important for the neurologist to know that, because he can tell if the brain activity is measuring up with the movement that we're seeing, or the twitches, or those types of things.
Okay, great. And do you, as far as interpretation goes, for your own sake, do you ever, if you notice that you're getting a lot of artifact, for example, do you ever check the EEG and notice that there's a lot of artifact, and then you do something to adjust the electrodes, or do something to address the behavior that's causing that artifact, or is that something that you're involved in, or?
Oh, 100%. Okay. So during the actual recording of the study, the neurologist is generally not there. And so although they can put the settings to the study how they like it, they can't change some things while it's recording. So if I have an electrode that's went bad and it distorts my study, I need to fix that immediately, or else the neurologist isn't going to be able to do his part in reading that. And, he may not read the study for an hour after it's recorded, so you can't go back in time. The technologist is definitely there to document, eliminate artifacts throughout the study, and present the neurologist with the cleanest recording possible, for sure.
Got it. Okay. And Dr. Keating, presumably then the primary function of the epileptologist or neurologist is to interpret the study. Are there other roles that, in terms of EEG, that you want to discuss as well?
Yeah, I kind of can be a little bit briefer about this. And so it depends on the situation of where the person is. And so really, the ordering provider of the study is the one who actually takes the report to the patient and tells them the results. And so in most situations, in a routine EEG, a short one, an inpatient or outpatient, an ambulatory EEG, a longer one, the reporting, the person who writes the report really writes what they think and say, and then it's up to the person who takes the report and talks to the patient, the ordering provider, to really interpret it and decide what to do. That being said, if I see something that's very concerning, or if my technologists come and tell me that there's something very concerning on this, I may act a little bit faster by calling the ordering provider or talking to them. And so that's one caveat. The other thing is, if you're in an epilepsy monitoring unit, once you get admitted onto our care, then we kind of make the decisions of what to do with the EEG recording. We talk to you about the results of the recording. We may make medication adjustments, and we might do all of that under the guise or with the guise of the ordering provider of that study. And so really, a lot of the times, the epileptologist or the neurophysiologist is like a radiologist, where we read what we see on an image, and then it's the requirement of the ordering provider to go to the next step and kind of taking that to the history and the physical and the exam and everything of the patient and deciding what to do next. Great.
Okay. So if a patient has a seizure while an EEG is being done, those findings are referred to as ictal EEG findings. In many cases, though, the patient doesn't have a seizure during the EEG, so all the EEG team can look for is those interictal abnormalities, which you mentioned before. Can you talk a bit about interictal epileptiform discharges and just give us kind of an overview of what they mean and how you use that information?
No problem. And so just a warning for everybody, I'm going to use some numbers, and so I'll try to not lose people. So EEG is the cornerstone of diagnosing epilepsy and other paroxysmal events. Routine outpatient EEGs in epilepsy are frequently non-diagnostic, or they don't give us an answer. Only about 29 to 55%, so about 25 to 50% of patients, of epilepsy patients, have epileptiform abnormalities on a single routine outpatient EEG. This yield may be increased by performing serial studies or by doing prolonged ambulatory or longer studies that will increase our yield to identify interictal epileptiform discharges in patients with normal or non-epileptiform routine EEGs. And it might increase the yield to up to 30%, and so that's still not that high. Really, the gold standard is to capture an event on EEG. And so we typically send people to the epilepsy monitoring unit, take them off their medication, and try to provoke these so that we can see what they look like. The highest diagnostic yield are in those patients who are in state transition. And so what do I mean by that? And so we kind of said it before. And so capturing somebody from awake, drowsy, stage 2 sleep, or deeper stages of sleep is critical. It's kind of like if you go in and say your car makes a noise or your engine makes a noise when you're on the highway. Well, a mechanic doesn't just look at your engine when it's stopped. They usually will rev it through its frequencies to see if they can reproduce that noise. And so when the brain is awake, it's processing a lot of information, and so the brain waves can look somewhat chaotic. And when we get into sleep, there are really only certain hallmarks of sleep that come about, and the EEG is relatively quiet. And so things that look epileptiform or look like interictal activity can pop out a little bit more. And so we typically want somebody to sleep for at least a few minutes. If not, the best yield is if we have somebody sleeping for an hour or longer. And so there's really certain types of epilepsy that have higher frequencies of interictal activity. Most commonly in a generalized epilepsy, so somebody with absence seizures or juvenile myoclonic epilepsy will see interictal activity on a routine EEG. However, in localization-related epilepsy or a focal epilepsy, if temporal, we'll see it maybe up to 30% of the studies, whereas if it's more of a frontal lobe, parietal lobe, or occipital epilepsy, we may see interictal activity in less than 10% of studies. And so that's why I say the gold standard is really to capture an event. The yield of the study is variable based on the duration and type of epilepsy, the events, the findings we are looking for to capture. There's really no cookie-cutter response for this. And so EEG is an extension of our history, exam, and clinical suspicion. Therefore, we may have a yield as high as 94% or as low as less than 10%, but really clinical suspicion is kind of what drives us to go further. It's just not the test. And so some people are diagnosed with epilepsy and they don't have interictal abnormalities, but everything else tells us this. And there might be people who have interictal epileptiform activity, but they don't have epilepsy definitively. And so it's kind of my roundabout answer for that.
Right. So if someone has been seizure-free for a significant amount of time, like 6 months or more, for example, but an EEG shows interictal epileptiform discharges, how does that impact prognosis and treatment decisions, and then also whether or not the individual should drive?
Yeah, so that's a really, really, really good question, and there are so many variables to that, and so it really has to be individualized to the patient. And so in the state of Michigan, no matter if you have a seizure or a loss of consciousness or any event that could preclude you from driving, you're not allowed to drive for 6 months. The state doesn't take your license away. I don't take your license away as a neurologist. It's kind of a conversation that we have. The biggest thing I tell my patients is not only ethically and kind of morally, if we get in a car accident and we hurt somebody else, it's one thing to deal with because I've seen people who have dealt with that before. But the other big thing, too, is that if you get in a car accident and they go to investigate your medical records and see that you have uncontrolled epilepsy, they don't. The insurance companies don't always have to pay for your medical expenses, nor do they have to pay for your insurance expenses because they said that you couldn't drive. And so that's kind of an important thing. So it's really dependent on what your epileptologist says specifically. The other thing is when talking about treatment decisions and prognosis and impacting your daily life and coming off medications, there's really no guideline for that. We don't have a specific guideline. We say if somebody's been seizure-free for 2 years, then we can take them off their medication, but there's a lot of factors that come into play with that, and so it's really, there's no cookie-cutter response to that either.
Right. So I guess the bottom line, though, is that the presence of interictal epileptiform discharges doesn't necessarily mean that you're at higher risk for seizures. Is that what you're saying?
No.
Okay.
No. It's yeah. So if you there's a study that came out, I think in the last 2 years here, where they looked at patient populations and taking them off medication, and sometimes depending on what your previous history was, even if you had epileptiform discharges on an EEG, that doesn't remove you from the ability to take somebody off of medication. It certainly gives doctors a pause and makes them think about their history, but there's really, I can't definitively say people will have or have not a seizure in the future. They may go on to have another one. And off medication, if they do have another seizure, that typically means that they will be on medication for the rest of their life. And so once you have a breakthrough off medication when you've had a seizure-free period, that typically means that you will, for your rest of your life, have an 84% or greater chance of having subsequent seizures.
Right. Okay. So interpreting EEGs correctly in relation to video or clinical findings takes a lot of skill and experience, which you've referenced that. So unfortunately, not everyone who interprets EEG findings has the same level of skill and experience. What are some common errors in EEG interpretation and seizure observation that you've run across?
Yeah, so this is a question that when reading through things, it's kind of like opening Pandora's box a little bit. And so it's kind of building on information that I said before, is that as we get a much newer generation of neurologists, they are relying more on epileptologists or neurophysiologists to read EEGs to decrease the risk of having errors happening. And so we're doing better from that standpoint. And actually, the other thing too is that if these are epileptic or non-epileptic, these people keep having their events, and so they will ultimately end up in an epilepsy monitoring unit to be recorded and evaluated. And so if you look at numbers, it's relatively high that a number of people will be something called pseudo-resistant to medication, where we didn't get the diagnosis right, or we diagnose somebody who doesn't have an epilepsy and has something else. And so that's why the American Academy of Neurology says if somebody is not seizure-free after 2 years of seeing a neurologist, then they have to see an epileptologist. And if they're seeing a general practitioner, it's actually less time than that to see a general neurologist. It's about 12 to 18 months. And so really getting people into the right hands quickly is the most important thing. And so some of the errors that we can see is diagnosing somebody with conversion disorder with non-epileptic seizures without a video EEG confirmation. And so the conversion disorder with non-epileptic seizures or psychogenic non-epileptic attacks, there's a bunch of different names for it. Really the gold standard for diagnosing a patient with this is to capture an event on video EEG, or at least on video. If we see it on video, sometimes we can, as epileptologists or clinical neurophysiologists, we can tell what looks epileptic or not. However, a small percentage of patients with non-epileptic seizures also have epileptic seizures, and therefore capturing the patient's events and brainwaves are the best way to really confirm or refute the diagnosis. Mistaking artifact for epileptiform activity is another one. That's a tough one, and that's kind of been developed over time. We're getting better at learning what are benign variants, and we're teaching everybody what benign variants are. And so the mantra now is if there's something that looks abnormal, take it to the physician who ordered or read the study. Should really be taking it to somebody who reads these on a daily basis, whether that be an epileptologist or a neurophysiologist, to confirm or refute what they think is going on. That's kind of the same thing for normal patterns. The overlook of subtle epileptiform activity can happen too, and so if we have subtle EEG changes that may not look abnormal when somebody's awake, we want to subcategorize and figure out what somebody's epilepsy is, and so they will typically get to an epilepsy monitoring unit or see an epileptologist to further diagnose it. And so a lot of these, there's really not any good answer or fix to. It's just things that we sometimes will see, and the patients will either keep having events or be misdiagnosed and come in for more information. There's really no way that a patient would be able to tell the difference unless they keep having this events. A lot of times people get misdiagnosed with frontal lobe seizures as being non-epileptic. That's typically something that will happen in an outpatient setting, kind of like if somebody's diagnosed with non-epileptic seizures without a video EEG confirmation. Really doing a video EEG, talking to an epileptologist, most people are able to tease these out, and we do specific education regarding that. But really, frontal lobe seizures are out of sleep. They occur when somebody's asleep. They occur very, very frequently, and they come in host with other seizures, and so people can have generalized convulsing or grand mal seizures. And so it's a rarity nowadays that people get misinterpreted as frontal lobe seizures as non-epileptic. And then the last one that is kind of in my bullets is assuming that a normal interictal or in-between seizure EEG means that the patient doesn't have epilepsy. And so we talked about this before, and this can and may happen. And so that's why if seizures remain uncategorized or undiagnosed or uncontrolled, we really recommend, like I said before, having the patient see an epilepsy specialist.
Great. Are there any special qualifications patients should look for in their neurologist and their neurodiagnostic technologist that will increase the likelihood of accurate EEG testing and interpretation?
Yeah, and I mean, so if the diagnosis is under question or seizures are uncontrolled for more than 2 years despite treatment, the AA and epilepsy guidelines state they should be seen by an epilepsy center. And so looking for an epilepsy center or an epileptologist or a clinical neurophysiologist would be the best. There's really, with regards to board certification and everything like that, that does help, but the best thing I can say is being seen at an epilepsy center would probably be your best bet to move to next.
Right. And Kimberly, are there certain certifications or qualifications that can vary from among neurodiagnostic technologists?
Yeah, absolutely. So it is perfectly legal for a technologist to be trained on the job to perform EEGs. That is currently the way it is, but soon enough won't be the way it is. We are now recommending that technologists do go to a CAHEP-accredited school, preferably with an associate's degree. Really what our main focus is that our technologists are registered. So in order to be a registered technologist, that means that you passed your board exams. So upon passing your board exams, you earn your credentials of R.EEGT, and it's also proving that you're proficient in EEG. Now, I don't want to say that somebody who isn't boarded, they may be very proficient. They may have been on the job for 30 years doing EEGs, but our standard now is changing, and we're trying to really have our technologists go to a CAHEP-accredited program and pass their board exams.
And what's the acronym there?
You are, in fact.
CAHEP?
CAHEP. It's CAAHEP. So that's the accrediting body that comes in and says the program that you're attending for this allied health profession is up to standards, and you're following all of the protocols, and the content that you're teaching is excellent. And so it's when you go to a CAHEP accredited program, it's saying that you're going to a qualified institution.
Got it. Okay. So the value of an EEG study depends not only on the quality of the interpretation, but also on the quality of the study itself. So Kimberly, can you talk about the various factors that can negatively impact the quality of EEG findings and how the skill of the neurodiagnostic technologist contributes to that EEG quality?
Yeah, absolutely. There are definitely several things that can lead to a poor study. Artifact is something that skews the recording that is not brain-related, so it makes the recording hard to read. Poor electrode application will lead to something called electrode pops. It's an artifact that distorts the channel that the pop is located, and if it makes that channel null and void until the pop is fixed or reapplied. You also have situations where your electrodes can just decide that they don't really want to work anymore. So your technologist needs to spot that and replace the electrodes so that you have a nice clean recording. We also have to run defense on things like muscle artifact and movement. Anytime you have this, it creates an artifact that can completely distort your tracing and can make it nearly impossible for your neurologist to read the study. So techs are frequently stressing that the patient needs to be still and calm, and we're always trying to create this calm and peaceful environment during the test. And it's because our electrodes are so susceptible to the movement, and the movement creates this artifact that makes it hard for our neurologist to actually see the brain activity. So our goal, of course, is to give our neurologists a study that's clean and easy to read and reflects brain activity, not movement. Or, sweat, for example, can create an artifact that almost looks like your tracing is melting. And so, most facilities have a fan for that reason. The tech would turn on the fan. We'd try to cool the patient down. Electrical noise is a problem for EEG, so we do have filters for this, but really the best way is to try to eliminate the noise and that sort of thing. But a good tech is going to spot your artifacts quickly and fix them. And from a patient perspective, it might seem kind of silly if they're asking you to do weird things like open your mouth during the recording, but really they're doing that because you might be biting down, on your teeth, and you're creating an artifact in that way. So they're asking you, release your jaw, so we're not getting that artifact in the recording. EEG can be tough for our pediatrics because we're constantly saying, wanting our patients to relax and lie still, so we can again give them that clean tracing. And it can be hard for our young patients, but still necessary. We have to do our best to get the best study.
Yeah, that brings up an interesting point. Sorry, go ahead.
Yes. I was just going to say that you said one thing, or to mention another thing that makes it hard for the EEG recording, and an oily scalp can make it difficult. So it's hard to get a good connection to the scalp. We all have a natural oil on our head, but that's why it's important to come into the study with clean hair to make your electrodes adhere that much easier to the scalp.
Right, and so you mentioned, I hadn't thought about this before, but do you have any specific strategies for, a child with ADHD with the hyperactivity component, like who just physically has difficulty sitting still? Does that, have you encountered that before?
This can be tough because...
Yeah. Go ahead.
We've had patients that, will come in and say, we didn't give him his medicine today. And, I know he needs to sit still for this study. And so we would prefer that they did have their ADHD medication so that they are able to sit still. We certainly want them to eat. So we have some people just kind of associate procedures by, I probably shouldn't eat or drink anything before the study, and not the case for EEG, because we want you to come in really comfortable. So especially for a pediatric, if they're hungry, they're going to be crabby and move around that much more. So we definitely want the patients to have a snack before they come in. They might also be sleep deprived, which is going to make things a little bit tougher. Comfortable clothes. If we have more than one technologist available, a lot of times we'll have one that's kind of entertaining the patient while the other one is working. But parents really can play a huge role in helping us get the best study, and that's going to be, holding and comforting the child and helping them to sit still. And sometimes that might mean we're, letting them watch your phone while we're doing the setup, or you brought in a special toy that they can use, or if it's a pediatric that would still be using a pacifier or a bottle, be sure to have those on hand, or a special blanket, so that they can be comforted and hopefully lie still as long as possible.
Right. Great. So what are some of the limitations of EEG as a diagnostic tool? And can each of you give an example of a challenging case that maybe highlighted one of those limitations?
So it's really, like I kind of said before, the limitations of EEG is knowing what you're looking for and knowing what you're not looking for as a neurologist and a clinician. And so the test is really only as good as what you're looking for or not looking for. And so it really depends. There's not one clear-cut answer. And so going in and knowing what you're looking for, knowing what data you're trying to get out of it, is much better than just getting the test done because it's a test to check things off. If the capturability of figuring out diagnosing somebody with epilepsy on a study that we have is anywhere between less than 10% and 94% accurate, really the test is there as an extension of what we're doing to help the patient. And so I would say that it's just based on clinical experience and time.
Okay. Are there specific strategies you can take to detect seizures or epileptiform activity that may be coming from deeper structures in the brain, or or that may be just like a focal aware seizure, for example, that may not produce enough of enough electrical activity to be detected. Are there ways of detecting that type of activity that that otherwise, in terms of how you do the EEG or how you look for it in the findings? I guess, can you talk a little bit more about that, the activity that may be hard to detect?
So a lot of times there's activity that's hard to detect because we're really good at seeing abnormal brain waves that are on the scalp or on the cortex or the outer surface of the brain, but when they occur deep in folds of the brain, it's sometimes hard to get to the surface. And so there's a certain study that we can do sometimes when the epileptologist or neurophysiologist feels that we haven't been able to categorize somebody's epilepsy and really think that they would benefit from an epilepsy surgery because they keep having seizures. And so we can send them for a test called a magnetoencephalogram, which is a magnet EEG, where we actually use magnetic fields. We record magnetic fields in the brain, and sometimes that can give us ideas of where deeper sources of abnormal brainwave activity comes from. The other thing we may do is we can put specialized electrodes in kind of right above the level of the jaw in front of the ear. They're called sphenoid electrodes, and we can actually record the under part of the temporal lobe, and sometimes that can give us some information. But really, the gold standard is to capture an event occurring, and so I keep kind of harping on that. And so it's important for us to capture one of these occurring, hopefully on EEG, but sometimes also on video. And so in the day and age of people having technology and good cell phones, if family can record a seizure on video, that can help the epilepsy team further treat somebody.
Right, and speaking and talking about focal aware seizures, am I correct in this, that there's a button people can press if they're having one of those seizures? And how often are you able to actually see a corresponding abnormality if someone indicates that, hey, I'm having a seizure right now?
Yeah. On scalp EEG, it's tough. You need about a $50 size part of the brain seizing in unison to actually capture it on a scalp EEG. And so a lot of times focal aware or focal impaired aware seizures or simple partial seizures can occur over and over again, and they cannot show abnormal EEG activity. And so we start to use our brain to figure out, from a neurologic standpoint, to figure out, are these the same technology? Do they correlate with what the patient is saying and with their other seizure types? And then the biggest thing is when you go into an epilepsy monitoring unit or you go into a routine EEG or an ambulatory EEG, patients will have a button to press, or if it's an ambulatory at-home EEG, they'll have something to write down what's occurring and what they feel. And so in an epilepsy monitoring unit, if they press the button, they can describe over the camera what they're feeling. And so sometimes we can correlate that and or talk back to the people. But it's a plus minus, and there's really no defined numbers of likelihood that we're able to, on a scalp EEG, correlate
right.
a partial seizure, a simple partial seizure, or a focal aware seizure with abnormalities on EEG.
Right. Okay. Can each of you describe a challenging case where EEG provided some sort of breakthrough in your understanding and treatment of a patient's epilepsy, just to kind of illustrate how valuable EEG can be?
Yeah. Let me think. So I have a patient who I started seeing since I started at my practice at Michigan State University. He is a young gentleman who has seen a number of different epileptologists and has been told he has non-epileptic seizures. He's been told he has epilepsy seizures. And so we brought him into the epilepsy monitoring unit to capture his events. We found no no EEG correlate with his events, and his events were very variable. And he was on about 5 or 6 different medications. He was actually considered by another neurologist as a surgical candidate to want to explore somebody for surgery, which would mean resection of a part of the brain or implanting a device to stop seizures. And so when I saw him and evaluated him in the epilepsy monitor unit, when I got his history and saw everything that was going on, I ultimately diagnosed him with non-epileptic seizures. We've since taken him off all 5 of his medications. We have him seeing one of our neuropsychologists who specialize in non-epileptic seizures. We do see a lot of patients here at Michigan State with non-epileptic seizures, and we're trying to do a lot more research on that to become a hub or a center for non-epileptic seizures. And since that time, he's actually been seizure-free. He started having seizures when he was 16 or 15, and he had to stop school, and so he's completed his GED. He's going on to work at LCC and possibly go on to a new career path. And so really, it's whether it's epilepsy or not, we have the ability to change people's lives with these diagnoses and make sure that we get the right diagnosis. And so that's just one example of many.
That's a great example. Kimberly, can you think of any?
So I used to work in an epilepsy monitoring unit, and that is just a fantastic place to get experience, and you see so many interesting cases there. But a classic case for me is seeing a patient with both non-epileptic events and electrographic seizures. We had a patient that suffered for years trying to get a hold of her seizures, and she actually did know that she had non-epileptic seizures. But during her EMU stay, we were able to actually find out that she had both. And so I think for her, she knew that some of her events were different than the other ones, but it was actually finally giving her clarity as to what was going on with her, and the fact that, yes, she did have non-epileptic, but she also had epileptic events as well. And we had proof of it, and it was proof for herself and for her family, and it was priceless for her. She was actually able to really finally have a diagnosis that was accurate for her and really encompassed all of her, not just that one piece.
Right.
And, of course, there are always the cases that, based off of what you've read in the history, that you think may be non-epileptic, and then they will completely surprise you that they are absolutely epileptic events and certainly need our help. So I think it really makes me thankful for tools like EEG, because it helps make those diagnoses that are really difficult and certainly helps people.
Mm-hmm. So I think the bottom line in both of those situations is that if you're, not confident about a diagnosis you've gotten from one neurologist or one epilepsy center, it's never a bad idea to get a second opinion, because just different way of looking at it, or different approach, or different circumstances might lead to completely different diagnosis. So if you have that suspicion that I'm not 100% confident about this diagnosis, we're fortunate in Michigan to have multiple epilepsy centers and many epileptologists. So definitely encourage people to get a second opinion if they're not feeling great about the accuracy of their diagnosis. So.
And the one caveat I'll kind of say with that too is that I think that the subspecialists should always reach out to other people too. And so in this day and age, most neurologists and epileptologists feel appropriate about getting second opinions, both for patients and then both behind closed doors to review the data that's been given. And so I think we're a lot more collegial nowadays. Right. And so I would say it would be very odd for somebody to not allow you to see somebody else if you want to see somebody else.
That's a great point. Okay, so EEG plays an important role in understanding nocturnal seizures and certain types of abnormal electrical activity that occur during sleep. Can you talk about how the electrical activity in the brain changes during sleep and how to capture these changes through EEG?
Yep, and so I'll try to be brief about this because we kind of talked about it before. But like I said, when people are awake, the brain waves are quite chaotic because they're processing a lot of information. As we go into sleep, our sleep becomes more regimented. We see certain structures in sleep that pop up, like we're watching birds. We see certain things in sleep, like sleep spindles. We can see things called K-complexes or vertex waves. They're all things that we've developed that are normal in sleep, and the rest of the activity of the brain kind of calms down. And so in those, we can see abnormal activity of both sleep, or we can also see abnormal in-between seizure activity. We can see seizures happen during sleep. We can see subclinical seizures where we're not having outward symptoms and they happen during sleep, or we can see erratic brain activity, or where the brain becomes very, very active in certain types of epilepsy when we sleep and we can't process information. And so seeing sleep on EEG or getting somebody to sleep on EEG is very, very helpful for an epileptologist.
Right, great. Can you just briefly, again, talk about any recent advances in the EEG technology or practice that are really helping to enhance the accuracy and detail in both diagnosis and pre-surgical evaluation?
Yep. Yep, and so I think we covered some of them, and so I'll kind of be brief. And so we talked about magnetoencephalography, or the brain scalp that, or the brain test that measures magnetic fields of the brain. We also talked about something called responsive neurostimulation, or RNS. That's when we stick an electrode into a certain part of the brain, and we that can cause that has seizure activity in it, and we listen like an EEG would. And when we find a seizure, we actually shock that area of the brain to stop a seizure happening. We also have different types of MRIs that exist these days. We have functional MRIs that can give us information how parts of the brain are functioning. We have things called PET scans, which are SPECT scans, which can tell us about certain activity or metabolism of products in the brain. We have something called Stereotactic Eeg, where we actually drill. This is for somebody who would be a surgical candidate, and we know that somebody's seizures are maybe starting in the temporal lobe or the frontal lobe, but to pinpoint exactly to a centimeter difference of where they're occurring, we have to get a little bit fancier to do that and go inside of the scalp to record the brain waves next to the areas of the brain. And so we can actually make a small hole in the skull and put a small strip of electrodes into the brain tissue without compromising or affecting that brain tissue, to listen and to ultimately see if somebody is a candidate for epilepsy surgery. And we actually, those EEGs electrodes, we actually have machines that compare your MRIs and tell us where it is okay in your brain to put these electrodes.
Great, great. Okay, so I think given the time, I want to make sure we have enough time for a Q&A, so we'll go ahead and open it up to Q&A. Okay, does anyone have a question?
Okay, my name is Sriram. My son was diagnosed with Dravet syndrome, and luckily, touch wood, it's been controlled now. But the thing is, every morning, like when he wakes up, he has a minor seizure every day. So we have scheduled for an EEG. Like, would we be able to find like what is the cause using this EEG? Like, why is he having this morning stuff which is not being controlled?
Yep. And so the goal would be to capture one of these happen in the morning. And so getting an EEG when he's having an event, or getting a prolonged EEG over a couple mornings, or at least one morning from sleep into awake, would be the most helpful in giving us the information. And so I would say that an EEG would help. It would just depend on the subtype of EEG. Sometimes an epilepsy monitor unit admission would help, where we record somebody's brainwaves overnight and then we repeat them. We continue it through the morning to capture it.
Okay, thank you.
Great. Did another person have a question?
Hi, I also had a question. My adult daughter has been through several other video EEGs, but the most recent one has been, I believe, 8 years ago, I apologize, I was late to the conversation, so you might have addressed this. I'm wondering what advances might yield more information for her if she were to have a video EEG done now. The last ones showed very rapid generalization, multiple focal points, and I'm wondering what's new in this in the EEG technology that might allow us to learn things we couldn't learn 8 years ago.
That's a good question, and I have a couple questions for you. The video EEGs that you're talking about, were these EEGs where the patient was admitted, or your daughter was admitted to the hospital and we recorded them over multiple days, or was this an at-home study?
It was in the hospital.
I had him over there,
She was
and
in
I
a
saw her
hospital?
call for assistance.
Yeah, she was admitted for several days, withdrawn from medication, observed.
And so it would really depend on what they captured on those studies when she was in the hospital. If they captured seizures and abnormalities, a new EEG would really tell us, it may tell us the same exact thing. The biggest thing that I can say is that just by your description and everything, it sounds like she has a little bit of a complicated epilepsy. And so to talk to your physician who's treating, or talk to an different epileptologist, or get a second opinion about updates or differences in what we can do or can't do for people that have changed over the last 8 years may prove more yield than actually sending her for a diagnostic study that is relatively static. And so this is kind of what I was talking about before, that for a neurologist, really the EEG is an extension of our exam. And so if we're just doing a study to look at what's going on with the brain versus if we're taking the information and talking about what's changed or what new options may be out there, there might be more of a benefit of talking to a subspecialist about what we can do that's changed in the last 8 years than getting a repeat study.
Okay. Yeah, thank you. Yeah, and she has, because she's moved since then, she's just beginning to be seen by somebody new, so it's a good opportunity for that.
Mm-hmm.
Great. Other questions?
This is Marissa, and I just want to, I don't have a question, just a comment. I've had several EEGs. The last one was back in 2015, and I fit into the category of the non-epileptic and epileptic seizure. And I'm due to see my neurologist again in the next month or two. So I got a question. How often should a person get the EEG, or, be able to have an EEG done?
So that's a very good question. And so most insurance companies will cover as many EEGs are as medically necessary, but definitively cover a EEG at least yearly. From my standpoint, I only obtain EEGs if I need to. So if somebody is breaking through a lot and I feel like their seizures have changed, if we haven't defined what kind of epilepsy somebody has, if people are having new events, or we're taking somebody off of medication, those are the reasons that I would do EEGs. There's really not a lot of great data for us to do spot EEGs, where we just do them to see where things are. It's not like an EKG test where we just check the heart because the heart could be functioning abnormally and we won't see anything. And so it's really a case-by-case basis, and there's no right or wrong answer for it. But really, there's no cookie-cutter kind of response of saying, yep, every year you should be getting it done, kind of like we get yearly labs done.
Okay. All right. Thank you.
You're welcome.
Okay. Other questions? Oh, while people think, I do have a question myself. How far away do we think we are from having commercially available wearable devices that use EEG to detect seizures and alert caregivers, or even predict seizures?
So there's a couple things. And so there is a wrist device. It's called the Embrace Watch. It is there to really capture people who have motor seizures or movement seizures, especially generalized tonic-clonic. And when it picks up that sensitive marker, it will actually activate its GPS carrying system and connect to a phone system, and then ultimately contact the people who we recognize as caregivers to say that somebody had a seizure. There's a lot of false positives on those tests, so meaning that it can activate for other reasons too, and so the wearer might get a lot of notifications, but sometimes it can give peace of mind to patients and families in people who have high motor or lots of movement seizures. Having a wearable scalp device for EEG capturing, we are a very long way from. We don't have anything that can really do it efficiently, cleanly, and without a high risk of infection. And so really, I think that part of it, we're very technologically disadvantaged. If somebody has epilepsy seizures and has a area of brain that's active, we actually use the RNS or NeuroPace device that I had talked about before, and so that's an implantable system where we can detect seizures and ultimately treat seizures, and so those are followed on a 24/7 basis while the EEG is implanted, and so sometimes we can get information or glean information from that, and a lot of information is coming from that ultimately decides or will help us be able to do the next gold, or I guess the next holy grail of neurology and epileptology, which is seizure forecasting. And so saying that, look, this is how many seizures you had last month, this is how many seizures you'll have next month, or this is your likelihood tomorrow of having seizures. We're not there yet, but we're getting more information to be able to get there, and that is a goal of the International League Against Epilepsy.
And do you know how that works in terms of all of the data that is gathered from NeuroPace, from patients who have the RNS system? Can a researcher, like an independent researcher or someone with an institution who wants to kind of use that big data set, even like de-identified data, would they be able to look at that to see if are certain patterns or things that we can learn from that data that would be broadly applicable or helpful for the epilepsy community as a whole?
So since there's only one device that exists, the RNS NeuroPace device, it's really dependent on what NeuroPace would be willing to release.
Yeah.
I can tell you that, however, NeuroPace is making their data sets very widely available, and so there's a lot of studies being done on epilepsy forecasting, and so those are things that are coming out now. And so there's a couple labs that are doing that specifically, I think in the West, so like Western America.
Okay, great. And another follow-up question to that, there's caps that can be worn with electrodes kind of built into them. I know there's some various devices like that. Kimberly, can you talk to whether that is even can possibly be an effective way to get EEG data? It seems like it would be unlikely given how each head is different, like you were saying before. What are your thoughts on those kind of EEG caps that can be worn?
Yeah, I actually demoed one not too long ago to see if any advances had really been made on the cap. The cap is difficult because it does come in like a small, medium, large category, and we are very unique. That's why it's really important to measure and mark the head and, apply them kind of one by one, even though it's time-consuming. My findings with the cap is that they were not really reliable, and if I were to have a perfect scenario where I think it could be reliable, it would be on a patient that was bald and happened to really kind of fit that specific cap size. I found it was very difficult to get a good connection to the scalp with the hair because it was a cap, and I couldn't really separate the hair to get the cap down to the scalp.
Okay.
Now, having said that, I mean, there may be some situations where you just have the perfect head for this cap, and they're able to get a really, great connection. But ultimately, it's not reliable, in my opinion.
Right. Okay. Great. I have a couple minutes left. Any other questions? Okay, I guess we will go ahead and wrap up the call. So thank you both, Dr. Keating and Kimberly, for an excellent presentation and really went into a lot of detail on a complex topic. So, and thank you everyone for participating. I just want to remind everyone, if you have further questions, please feel free to contact Epilepsy Foundation of Michigan at 1-800-377-6226 or visit our website at epilepsymichigan.org. So thanks again, and our next Learn and Share conference call is on autism and epilepsy, and that's on July 10th from 6 o'clock to 7:30 p.m. So hopefully anyone who's interested will join us for that. So thanks again to our presenters and for everyone for joining us.
Thank you.